So we'll talk about the immunotherapy, and since this is the first session about immunotherapy, I'm just going to give some basic introduction, and then along the way I'll argue about why it should be, or preferably it's done in one way. I do want to thank my wonderful colleagues Julie Bramer and Roy Herbst for some of the slides I'm going to use, and these are my disclosures. If you think about it, the immune system ought to do a good job. This is a beautiful review article written by my colleague Bob Schreiber from Washington University. He actually, he prefers to use the term immunoediting as opposed to immunosurveillance. Semantics aside, the key point is that as the cancer cells evolve, these clones emerge, new clones come up, they express new antigens. After all, I'll show you later in the day, lung cancer is a disease where we see minimum, on an average, 200 to 300 mutations that we can count when we look at the coding regions per tumor. Not like one mutation, one tumor. These tumors have been sitting around for a long time. They've been exposed to carcinogens for most of their lives, and so they have picked up a lot of these mutations. So what they do is that these mutations eventually produce novel epitopes and that are expressed on the cell surface, and these are not that the patients were born with. So if you really follow the logic, the immune system should identify these proteins and cull them out and should be able to destroy them, and perhaps it happens quite a bit. But at some point, this process fails, and it fails for many reasons. Either the immune system gets paralyzed, just gets exhausted, because cannot go after that. There is a fantastic term, I forget now, it's called immune exhaustion or a T-cell exhaustion, that exhausted T-cell syndromes. And there are things that can exhaust the immune system. The other approach is that the immune cells or the cancer cells can actually activate some checkpoints or breaks that are inbuilt in the immune system. If you think about overrun immune system is just as dangerous as inactive immune system, because overrun immune system causes these autoimmune diseases, and of course the most dramatic example is you see in anaphylactic reactions. So immune system should be contained and should be restrained to a great extent, otherwise it can be quite dangerous. So there are beautiful systems that have evolved over the past several years, depending on your belief, or many millions of years or 5,000 years, and they have really have put a check on how we respond to that. And the question really is, do the cancer cells exploit that system to put the brakes so that the immune system does not kill the cancer cells? It probably does, and that's one reason these cells evolve. And for the past 15, 20 years, you've been pursuing this active immunotherapy, trying to do this vaccine and using one or two antigens. And while these were well-intentioned, at that time well thought out, I think the new approach is emerging in the immune field. And if one thing you can take away from this meeting is that this is actually the next large wave that is going to sweep across the cancer treatment landscape. And one of them is how to take the foot off the brake a little bit, let the immune system do its job. And that's basically the approach we'll talk about today, the PD-1 and the CTLA-4. And the other approach is there a way we can study the novel or altered epitopes, looking at the genes that are altered, and then create active immunotherapy based on the most potent antigen that's present on the cell surface? After all, these tumors express so many antigens, so many proteins, so many altered proteins, but not all of them may be useful. Maybe MAGE-A3 may not be the best example or may not be the best antigen that we can go after. But is there a way we can identify the antigen that we can selectively target, or select that particular antigen and create active immunotherapy? I won't talk about that today, but if you're interested, there were some nice papers published about a year ago in Nature, a couple of papers back to back, one from the Boston group, one from the group in St. Louis from our place, and both showed that that if you can do the sequencing, of the tumors, and actually you can do this in silico analysis through computer models, you can pick out the antigens that are most antigenic, and you can create active immunotherapy. That's one approach. I think it still remains to be seen whether that will work in human beings. These were animal models. And the other approach is to take the foot off the brake. And this cartoon shows, you may or may not be able to see it from the distance, essentially the cancer cells as they evolve, it's kept in some kind of a balance because of this immune system culling out those bad cells. At some point, perhaps a new mutation, new alterations, or perhaps overexpression of these ligands to apply the brakes eventually lets these cells evolve, and then the immune system eventually turns a blind eye to this. And that's how eventually the cancer cells do show up. And the other point you have to keep in mind, I'm sure many of you may have had patients who have had transplant. I've taken care of a bunch of patients, a handful, I should say, not a bunch, who have had transplantation and then developed metastatic cancer, and we have always had poor results with those patients. And so it's worth keeping in mind the immune system plays a role from these observations. So the PD-1 is the darling of all the cancer therapies today, especially for a couple of common cancers. And so this is basically the very nice cartoon from a nice editorial that accompanied the first PD-1 paper from lung cancer last year. So essentially, if you can see that, some speaker walked away with a laser pointer, but the bottom line is there are two, I think it's Jerry Azzoli. No, really? So, okay. So that's fine. I don't need a laser. So there are two things. As the cells get primed, the antigens are presented on the T cell surface, and then they actually, the first response is that the antigen is presented on the MHC molecule, and eventually generates the response. But that is not a very sustained response. For you to get a sustained response, you have to have the co-stimulatory molecule through B7, as you can see here. And the B7, but it's activated on the dendritic cells, eventually gives a boost to the T cells, and that in turn actually promotes the immunity. This is the great yin and yang, and around the same time, if the T cells express the brake protein, that actually does so within 48 hours or so, CTLA4 comes in play. The CTLA4 is the brake the T cells express so that the immune system does not go in the overdrive mode. The same B7, when it binds from the dendritic cell on the CTLA4 of the T cells, it actually stops the co-stimulatory molecule action by the B7-CD28 interaction you see on the top. So that in turn restrains the immune response. The immune response then becomes measured. So this is an acute event. The chronic events, like chronic viral infections, tumors, perhaps actually induce the activation of the PD-1 receptor on the dendritic cells, and on the T cells, sorry, and that in turn would be activated by some ligands, very likely expressed by the tumor or the tumor stroma, that in turn stimulates the PD-1. PD-1 is the brake that comes on in chronic infections, malignancies, and things like that. So it's possible that some tumors that express PD-1 early on or at some point eventually can activate this pathway and slows down the immune reaction against the cancer cells. So if you can create an antibody that blocks either the PD-1 receptor, as you can see on the T cells, or the PD-1 ligand, mop up the PD-1 ligand that is expressed on the tumor cells. So you can prevent these brakes from being applied, and therefore you can actually turn the immune system against the cancer cells. So that's the rationale behind why we use PD-1 or CTLA-4 therapy. And I thought I'll show you the data which many of you may have and many of you may not have seen. This was presented by Dr. Bramer at the last ASCO meeting just a few weeks ago. And these are the updated results from the PD-1. This is actually not the ligand, this is the PD-1 receptor, and as you see on the T cell surface. And this is the anti-PD-1 antibody nivolumab. And this is actually a large phase 1 study that included patients from a wide variety of other cancers. But the focus on this presentation, of course, our talk is going to be on lung cancer. And you may recall that 3 different doses were tested, 1, 3, and 10. The bottom line is 1 didn't look so good, 3 and 10 looked about the same. 3 milligram per kg IV every 2 weeks is going to be the dose that's being pursued. And even though it's a phase 1 study, 129 patients with lung cancer, standard group of lung cancer patients, nothing unusual here, enough patients with both squamous, non-squamous, non-small cell lung cancer. If you recall, about half, a little over half, had more than 3 or more lines of therapy. So these are patients who didn't come off from the street with newly diagnosed cancer. They've all had multiple lines of therapy, everyone had platinum-based therapy, as you can see here. And so this is a heavily pre-treated group of patients. So, leave aside the clutter of this slide where with 3 different dose levels. But the bottom line is, if you focus on the last column, and the median survival in this heavily pre-treated patients, 3rd and the 4th line setting, is ranging from 9 to 14 months. Not so bad. If you look at that, the 3 milligram dose looked pretty good. 15-month survival in 3 or plus previously treated patients is not bad at all. And the response rate you will see here, both at the 3 and the 10 milligram on the left-hand side, is about 20% or so, 20 to 25%. So 20% response. And this, if I'm not mistaken, is the first time a single agent immunotherapy produced a response rate of about 20%. And if you look at this overall, about 15 to 20%, and that glass ceiling has never been broken, about 10, 15% response rate. So really we see that as a single agent response rate, which is pretty good. And there was some discussion earlier on whether patients with one histological type did better than the other. My reading of that is not really. They look about the same. The numbers look a little bit different here and there. And if you look at all doses, about 9% overall, 9-month overall survival with squamous, about 10-month with adenocarcinoma, and the response rate is 16 and 17%. And if you look at the 3 milligram dose, it's about 22 or 26%. So the histology, in my opinion, doesn't matter here. And you can see nice responses. These are radiographic pictures Julie showed last year, if I'm not mistaken. Very nice responses. And the waterfall plots, and you can see here, again, not everybody responds to this. And I think about obviously 20% respond, and some clearly progress very early on. But what is interesting is that some of these patients, some responses are very durable, as you can see here. If you look at the duration of therapy, it's actually very impressive in a small proportion of patients. And interestingly, the red bars you see are those patients who continue to respond even after stopping therapy. So clearly it changes something profoundly how the immune system looks at these tumors in some patients. So challenge for us is to figure out who they are rather than giving it to every patient. I'm sure we are going to get there very soon. If you look at the kinetics, you can see that apart from the early progression earlier on, majority of them lay low and staying like that for quite some time, and it is quite interesting. These are the updated survival curves she presented as a poster this year, and the 1-year survival rate is about 42%, and the 2-year survival rate in this heavily pretreated patients is about 15 months. And the histology, again, in my opinion, doesn't make a big difference, and it works in both squamous and non-squamous. Of course, when you unleash the immune system, clearly it's going to have some consequences, and predictably you can get pneumonitis, colitis, autoimmune reactions from these things, and you have to be careful about them. These are not easy drugs to take care of. You have to manage them very quickly. I have lost a patient on immunotherapy on a trial, so these drugs are not benign, especially those with pre-existing colitis or other problems. You got to be extra careful. Keep in mind that this is not for everybody. Patients with existing autoimmune diseases should not be treated on these drugs because it can produce horrendous results, unfortunately. So this is something that we have to really see. And so overall, if you look at the PD-1, I'm just showing the summary for the PD-1 portion. The 3 milligram is the way to go. It produces about 15 to 20% response rates regardless of histology, and it works even in heavily pretreated patients, and some of the responses are very durable, and they are quite fascinating. So clearly, this is going to be a drug in the market at some point really soon. And of course, if PD-1 is good, why not PD-L1? Remember, I showed you that cartoon, that PD-1 and the PD-L1 expressed in the tumor cell surface. Can we go after the PD-L1 so perhaps it may be more tumor selective and less toxic to the host tissue? It's a growing industry, as you can see. The number of compounds, number of companies are involved in this. And in fact, Roy Herbst and David Spiegel presented this at the last ASCO. This is the the ligand targeted drug from Genentech. And again, similar theme, phase 1 study looking at different doses in a wide variety of tumors. In lung cancer, once again, the response rates are actually fairly decent, overall about 20% or so. But what is impressive here is that if you look at this small number, so you should not really jump into this too much, that if you look at the group of patients who had PD-L1 expression in the tumor cells, the response rate was a whopping 80%. But again, the number of patients is very small, 5 patients. So before we run into, this is not set in stone in my opinion. But also 14% or 15% of patients judged PD-L1 negative also responded. And any day, any of us would take a 15% response rate in the salvage setting. So that shows that the PD-L1 is an interesting marker. It probably can pick the best responders, but there are some who would benefit that you would not pick up by this. So we need to study a lot more before we say that we have a clear marker in randomized patients only based on that. There is some discussion in this PD-1 world that perhaps PD-L1 directed therapy may be much more, much maybe easier on the patients and maybe less toxic. I think it's too early to say that. And while there was all this discussion that you don't see pneumonitis with PD-L1 directed therapy because it's just on the tumor and it probably won't cause this pan-body T reaction, I'm not sure whether that's true. There have been a few reports I hear of pneumonitis seen in patients with PD-L1 directed therapy as well. So again, time would tell. And these are impressive results you can see with immunotherapy for these patients. And even more impressive, this is not lung cancer, but nevertheless quite impressive. You can see that beautiful healing of these rather dramatic skin lesions. And so a number of clinical trials are ongoing, and I really think you should consider either having those trials in your place or sending patients to those places, even if it's Memorial Sloan Kettering for those who live in New York. And so there are a number of these trials that are available. And this is very interesting. A study that was presented at ASCO combined PD-1 and CTLA-4 blockade in melanoma, where you sequentially block both. And so these are the results that really attracted a lot of attention. Melanoma. So both melanoma and lung cancer are really doing very well with this approach. I don't know whether this combination would work in lung cancer. Those studies are ongoing. This kind of a sequential combination of this doing both. As I told you, PD-1 is activated more in chronic diseases, chronic infection, cancer. And so I'm not too surprised, at least early on, the PD-1 looks a little bit better than the CTLA-4 directed therapy. Again, too early to say. This kind of a sequential therapy may be the way we will eventually approach cancer. So I think that is much more thoughtful. You take both the early breaks, let them off, and late breaks, and do them in a sensible fashion, watch for toxicities, and eventually, and more importantly, select why some people respond better than the others. If you ask me what's common between melanoma and lung cancer, why do they respond well? The amount of mutation that these tumors have are really identical. And in fact, if anything, melanoma looks worse than lung cancer when you do the genomic studies, and I'll show you one of the slides later on. And as there are more mutations, more altered protein, there is a greater chance immune therapy might work because there could be some antigen that the immune system can go after readily rather than tumors that have very low amount of mutation. That doesn't explain very well the kidney cancer story, why those things work, and I think we really need to understand all these things better. And finally, I almost forgot what I came to talk here, and that is we should use it as a monotherapy. Well, what I told you is a setup piece, basically for Jeff Oxnard to talk about this immune therapy in combination. Given the fact that we have seen such impressive responses, and we have seen this with PD-1 and perhaps at least in different disease, melanoma, both the combination of PD-1 and CTLA-4, I would rather pursue approaches that are scientifically based rather than mixing some chemotherapy empirically. And I think that is important. Also remember that if you could take you back to 15 years ago, when we just began developing EGFR TK inhibitors with gefitinib, there was the notion at that time that the pills will not do anything good for these patients. They need chemotherapy. And of course, we did a bunch of these chemotherapy trials, and none of them, even in EGFR mutant patients, have shown any benefit with the addition of chemotherapy or systemic cytotoxic chemotherapy with the targeted agents. So I think I personally am perfectly happy with a single agent at the present time. If scientifically we can combine them with something else, I'm perfectly fine. So the challenge is to find out the reason why the blues and the reds are behaving like the way they are behaving, how well they are doing. And I think we'll move the field forward, and that actually will really prompt more studies to understand how the immune editing happens in the cancer cells, so that could change the way we approach these patients. I'll stop here. Thank you very much.